Okay. Okay. So Lillian, so you have a 70-year-old that comes to you in a clinic having some falls, kind of chronic imbalance, no discrete vertigo attacks, just kind of having falls. No other real big complaints, other than some asymmetric hearing loss. Less is worse than right. No real facial complaints. Um, so what kinds of things do you want to know about that? Any other follow-up questions?
So this is a 70-year-old, and the history is repeated falls. So you first want to find the history associated with the falls. So the number of falls, the frequency, if they have any associated vertiginous symptoms, that is, if the patient feels like the room is spinning, or if the patient feels lightheaded, or if the patient has any, or if the patient feels lightheaded, or if the patient has any other symptoms like vomiting, palpitations that are associated with the falls. You also want to find out about other symptoms, other otological symptoms, such as oral fullness, tinnitus, other cervical symptoms, other head symptoms such as the presence of a headache, presence of an aura, and any other associated neural symptoms such as convulsions that are associated with the fall. Then
Mhm.
you also want to find out what happens during the fall. Does a patient lose consciousness, or does a patient retain their consciousness after they have the fall? That is, are they aware or not? And yes. Then on top of that, you also want to find out any history of comorbidities. So does a patient have diabetes, hypertension, and do they have a history of previous strokes or no strokes? And in the neurological evaluation, you want to find out if they have associated symptoms such as left-sided weakness. So not left-sided, but any form of weakness of the body, and the time duration of the falls.
Mhm.
And if
Okay.
there's any other associated injury, and if they have other problems when they are walking, and if they have hearing problems, that is any gross walking musculoskeletal abnormalities in ruling
Mhm.
out of the. Then you go now to the risk factors. You want to look at the body habitats. Does the patient have any other risk factors such as taking of alcohol, smoking, 70 or maybe history of drug use, yeah, and any
Yeah.
other.
Yeah. So as you think about, and I'm not sure how like board exams would go, but yeah, so you want to compartmentalize. So you want to think about HPI. So what are they complaining of, right? And then you'd say, well, I'd want to know their past medical, surgical medications. Are they starting new medications, allergies, social history, and then let the examiner say it. You guys don't, do you have a or oral exam, right? At all or no? And the
Yes,
residents do, but
yes.
yeah, yeah. So, it's just, yeah, so kind of compartmentalize it as you're almost like you're doing clinic. So you have a history of present illness, ask all the details about that, and then say, well, I would want to know about this. I want to know their past medical, and then let the reviewer would tell you that. So yeah, so he's a 70-year-old diabetic, kind of poorly controlled. These are not vertiginous attacks. They're just chronic imbalance, having some falls. Because he's diabetic, he does have some neuropathies, so he was want to ask about that as well, right? Do you have any peripheral numbness, tingling in the legs, any orthopedic issues, right? So a lot of people don't realize, they don't ask about orthopedic structural things, knees, hips, ankles, back, right? So those could put people at risk for falls as well. Um, but no other big issues. So on the physical exam, right? So what are you looking for on the physical? You mentioned his normal exam. You asked about otologic history. There's been no real otologic history. So no, I always ask about otorrhea, otalgia, previous ear surgery, right?
Yes.
So there's none of that. There's a little bit of a little hyposthesia, the left trigeminal nerve, kind of in the mandibular division, but the facial nerve is intact and symmetric in detail. On the neurootologic exam, the vestibular exam, it's relatively unremarkable. There's no spontaneous gaze evoked nystagmus, but he does have a positive head thrust to the left. Can you describe to me how you would have performed that exam? What do you do with the patient to get that information?
The head
And what
thrust.
does it and what does that mean? And what does that mean? Or what could it potentially mean?
So when you're doing the head thrust, you want to ask the patient to sit. You want to sit across the patient. You explain the procedure to them. So the thing that you're testing is that you're testing the peripheral vestibular system and ruling out any chronic or and actually you're looking for peripheral vestibular lesion. So you put the patient angled the head or the neck. First, you rule out any neck abnormalities. So you make sure the patient does not have any neck pain or neck stiffness or neck arthritis. You then ask the patient to tilt their head down by 30 degrees. That is to be on the plane of the horizontal canal. And then you often want to basically just loosen, ask the patient to fix their gaze onto one point. Most commonly, it is to your nose. And then after making slight movements, you want to make a sudden movement either to the right or to the left. And usually from what we do is with a sudden head movement, you want to check whether the patient develops what we call like nystagmus or a catch-up saccade, a corrective saccade where the eye is.
Right. So it's called a corrective or a corrective saccade, right? Or
Yeah.
refixation saccade, right?
Yes.
So when we say the head thrust is positive to the left, what does that mean?
So it means that the head thrust is, or rather when the patient's head is suddenly thrusted to the left, there is a corrective saccade that comes towards that side. But when it turns to the left, the patient is able to maintain the visual fixation.
Right. So what do you see? What do you see in the patient? What are you looking for when you say they can't refix? Can you describe what you see, the events? So you thrust them to the left.
So you thrust them to the left.
And what happens?
So the patient was fixed at you. So you thrust them to the left. The eye deviates to the deviates, and then it comes back to the left to fix onto your nose, which
Right.
is medially. Yeah. So it will
So
come
passes
back.
the target.
Yes, it passes. Yeah.
Okay. So what can you ascertain from that? You said it was a peripheral, might indicate a peripheral lesion in the ear. Is that affecting all balance canals, or what kind of information can you only say that you might be gleaning from that exam?
So
What you with a head thrust test, what balance canals and which nerves of the inner ear are you testing with that?
So with the head thrust, you're mainly testing the lateral canal.
Mm-hmm.
And
Okay.
because the lateral canal is the one that senses horizontal motion along the horizontal plane. And
Okay.
the lateral canal is supplied by the superior vestibular nerve.
Okay. What other structures are supplied by the superior vestibular nerve?
So the superior vestibular nerve usually supplies the lateral canal, the anterior canal, and the saccule.
Are you sure about that?
And one supplies the saccule, one supplies the utricle. So let me think about it. Let me just think about it.
Okay.
So,
Mm-hmm.
so the inferior canal supplies the utricle and the superior canal.
You mean the superior nerve? The
The
superior nerve
superior nerve.
supplies.
The superior nerve supplies the lateral canal. It supplies the posterior canal and the saccule.
Are you sure about that?
It's all confused now.
Okay, let's get this straight before we move forward. So superior
Okay, yeah,
vestibular nerve, inferior vestibular nerve, right? They're innervating different structures, right?
yeah.
You were right, almost got it on the first pass. So the superior vestibular nerve innervates the horizontal or the lateral semicircular canal, the superior or the anterior semicircular canal, and the utricle. Those are
Mm.
the three structures supplied by the superior vestibular nerve. So that said, then what does the inferior vestibular nerve innervate?
So that means that
What's left?
what's left is the posterior canal and the saccule.
Right. That's the inferior vestibular nerve. You got it. Right. So really important to get that distinction because on a head thrust test, you're limited on what you can determine, right? So what can you say? What kinds of things can you conclude from a positive head thrust test in the clinic? Or what can't you say? Depends on how you're saying it. So you're saying that obviously there's some elements of a vestibular loss, a peripheral vestibular loss, right?
Yeah. Yes.
But at what structures are you limited in concluding at that point? What kinds of things can you only say? With a head thrust test, can you comment about the posterior canal? Can you comment about the saccule? Can you comment about,
No,
you know,
you
right?
no, you cannot.
Right. So you really only can comment about the horizontal canal and somewhat of an index of the superior vestibular nerve, right? So is it possible to have a peripheral vestibular nerve lesion and you don't see a head thrust test? You don't see a corrective saccade on clinical exam.
Yes.
How's that? How's that possible?
Especially if the lesion is a lesion that is predominantly either a neuritis or a lesion affecting the inferior vestibular nerve, or rather it is a lesion that is affecting the superior nerve and sparing the inferior vestibular nerve, then you will not get a positive head thrust.
If it's affecting the superior vestibular nerve and not the inferior, you're not going to get a positive.
Yes, if it is affecting, if the lesion is sparing the inferior vestibular canal. So if you have a lesion of the superior nerve, sorry, and it is sparing the inferior nerve, then you will not get a positive head thrust.
Why is that? What did we say is innervating the superior vestibular nerve? Or what? So if your superior vestibular nerve is compromised,
Yes.
but the inferior is not,
Mhm.
how is it that you wouldn't get positive head thrust? Or would you expect a positive head thrust?
Because when you do the head thrust, then the patient will be able to maintain the gaze. They do not get the corrective saccade. So the
But
vestibulo-ocular reflex is
Mhm.
usually intact during that particular test.
But sorry to belabor this. This is just important.
Yes.
So we just said what does the superior vestibular nerve innervate?
We said the superior vestibular nerve innervates the lateral canal, the anterior canal, and the saccule. And
The
the
saccule
utricle,
or
and the
utricle?
utricle, sorry, the utricle, yes.
You'll have to write these down, right?
Yes, yeah,
So yeah, so we just said the superior vestibular nerve innervates the lateral canal, the superior canal, and the utricle.
yeah.
So if that's compromised in any way, if the superior vestibular nerve is not working unilaterally,
Mhm.
how is it that you won't see a corrective saccade with a horizontal canal or horizontal or a head thrust test? You just said if the superior vestibular nerve is compromised, but the inferior is not, You will not see a corrective saccade on head thrust. How is that?
No, that is the case where you will see a corrective saccade because the superior
Right.
is compromised. But if you have a lesion on the inferior only,
Mm-hmm.
then you will not have a positive head thrust
Right.
test.
Right.
Yes.
I think you flipped those around. That's why I was
Yeah.
clarifying. I'm not sure
Yes.
if you meant to say that or if it was just, yeah. Yeah. Brad has a question, comment.
I have a little comment. The way that
Yes.
I remember it is that the inferior nerve is not as important as the superior nerve. So you think of the inferior nerve as PS, like it's a kind of a postscript, PS, posterior canal and saccule. And then the others are all the superior nerve. That's how I remember it. PS,
Mhm.
it's a kind of an afterthought. Sorry
Yep.
about that. Just thought I'd
No,
throw
it's
that in.
good. No.
Thank
I
you.
used a
Yeah.
different one where um LSU over Penn State. This was a couple of colleges in the US. People would say LSU, Louisiana State over Penn State. It's a yeah, it's a reference. It's only, kind of limited, geographic limit. But it's just another way to remember it. So, however, that's a great one with Brad, because that's more universal. I would say just think of it, write that down and think of a way to remember that.
Mm.
It's an important way to think about these things because what you said was no, you're right. So somebody can have a peripheral vestibular nerve lesion, but you may not see the clinical manifestations of that with traditional bedside neurologic testing, right?
Yeah.
So, a head thrust test we do in this situation because someone's presenting with chronic imbalance and you're doing a good neurologic exam, you want to do a cerebellar exam. Is there any concern about cerebellar degeneration, Chiari malformations, ataxias? It's always important to do these exams. Now, we won't belabor it too much because we'll talk about vestibular again another time, but if they had a central, so this portends it sounds to me like he has a vestibular peripheral lesion, right?
Mhm.
Based on exam. What would be some telltale findings on the clinical exam that would suggest he had a central vestibular finding? Can you name two or three? Just two or three things that come to mind that you would suggest that the lesion could be central versus peripheral.
So when you're having a patient who you suspect or who you examine and you want to confirm a central lesion, one, you want the characteristics of the nystagmus. Usually the nystagmus is continuous. It is not direction. It does not follow. It's either an upward gazing or a downward gazing
So it
kind
could
of
be vertical,
mass,
right? You could
or
have a vertical
vertical. Yeah,
nystagmus,
it's not a
right?
purely horizontal
Okay, so
nystagmus.
vertical is pretty much not a peripheral unless you see, like a BPPV, but that's kind of rotary
Yeah.
upbeating. This would be spontaneous or
Mhm.
or even in a gaze evoked.
The
Uh-huh.
other the other thing is that usually it is not fatigable, so it is a continuous type of nystagmus. So
Mm-hmm.
the velocity doesn't really change. The other thing is that there is the aspect of direction changing nystagmus.
Mm-hmm.
So in yes, there's the direction changing. So basically, the central nystagmus does not follow the Alexander's law. Then the other thing is in the cerebellar exam. When you do a cerebellar exam, most of the time you can have a positive cerebellar exam. And the other important test that you can do to rule out a central origin is a test of skew, which is usually characteristic for patients with central lesions.
Okay. Okay. So important to do these exams really closely, right? Okay.
Yeah.
So you have a 70-year-old with chronic imbalance. Um, you noticing some hyposthesia in the V2 maxillary, the V2 distribution of the trigeminal nerve, and a ipsilateral head thrust test. What do you want to do next? What would you do with this patient? Or tell me some things you might be suspicious of based on what you know
Okay.
about what's going on. I don't have an audio to show you, but you can just say that they have an asymmetric sensory neural hearing loss.
So this patient has an asymmetric hearing loss. They have trigeminal nerve findings and they have vestibular findings. So you want to rule out several things. One, you want to rule out a CP angle lesion that could be compressing on all those components. You also want to rule out a neuropathy because the patient is diabetic and they could be having a neuropathy that is affecting all the multiple cranial nerves. And neuropathy, but yeah, would also
How
want
would
to.
how would a neuritis present? Would a neuritis present with chronic imbalance?
No, a neuritis usually presents with
Acute what?
acute vestibular symptoms. So they usually have acute vestibular, they have vomiting, they have vertigo, acute onset vertigo, and the fall will not be multiple chronic falls unless the patient has an old neuritis that was left. And so the patient has still not yet fully compensated for the old neuritis.
Could that be the case here?
It is possible.
Okay. But if they have hearing loss, would that be fitting with more of like a neuritis or another type of maybe vestibular sort of crisis event title? What other diagnosis would that be? What's
So
akin
it would
to
be it would
neuritis?
be a labyrinthitis. If there's involvement of hearing, it becomes a
Right.
labyrinthitis.
Right. Could add a labyrinthitis, right? And then
Yeah.
they haven't complicated, as you said. So really important to ask that in the history. Say, did you ever have what we call a crisis event where you're on your hands and knees, spinning uncontrollably, vomiting, had to go to the ER? So that's a really important question to ask I always ask that of patients in their otologic history, especially someone who's presenting like this, because you don't know something's, leading them to have this chronic imbalance. Okay, so all right, so that's good. That's good differential. So what's next? What do you do? Where do you want to go, or where do you want to go from here?
So from here, you want to do a pure tone audiogram because you want to confirm. You also
So
want
you get an audio, yeah. So I mentioned that the audio shows an asymmetric hearing loss. Sorry, I don't have an audio for this one.
okay, and then you now want to go to management.
Brad's got a comment. Sorry, Brad, go ahead.
And can you tell us a little more about the audiogram? You said you've got a pure tone. Did you also do speech testing?
Yeah, the
Yes.
speech is, yep. So pure tones are, they're relatively, so it's got an asymmetric pure tone and an asymmetric word descrim in both. So both are asymmetric.
Okay.
Normal tympanometry and acoustic reflexes were not performed.
Okay. So you have a patient, you have diagnosed a peripheral vestibular lesion. You want to do, and they have an asymmetrical hearing loss. So you also want to find out imaging so that you can complete your investigation battery. He also has, so you send this patient to do an MRI to rule out a CP angle lesion and any other form of neuritis or neuropathies that he could be having. You also want to do confirmatory tests, neurophysiological, like you want to send this patient for a VEM, vestibular evoked myogenic responses.
Okay, so why are you doing that? Is that necessary to do that now? The timing between imaging and that? Can you talk me through that a little bit? What are you looking for there? What does a VEMP tell you?
So no, actually the VEMPs are not as important as doing VHIT, like the VHIT tests. Because a VEMP will just tell you or will help you specify whether you have a lesion in the superior nerve or in the inferior vestibular nerve. So if you do cervicogenic VEMPs, then they are specific for the superior nerve as compared to the ocular VEMPs.
So what would be, okay, so what would be the next most important thing to get?
Imaging.
Let's see. Okay. All right. And what kind of, what are you looking for? What kind of study do you want to get?
So we want to do a gadolinium enhanced MRI of
Okay.
the internal auditory meatus.
Mm-hmm.
And that is to mainly rule out a CP angle lesion from the T1 and T2. The MRI will also be good because it is going to give us a lot of information on the neural architecture of the brain, including the cerebellum, in case he has any other neurodegenerative illnesses that could be causing these symptoms.
Okay. And what if you can't get an MRI? What if they say, well, he's got a pacemaker, or he's got metal in his body that's not compatible with an MRI? What are your other options?
So because of the presentation with a trigeminal neuralgia affecting V2, you would think that if he has a CP angle lesion, it's quite a big lesion that could be visible on CT scan. And so you can also ask for a CT scan with contrast.
Okay. What kind of CT? Just the head CT, max face?
No, you want to do a high resolution CT scan of the temporal bone.
What? Those are probably temporal bone. Okay.
Yes, of the temporal bone.
Okay. And we'll talk about some testing in a little bit, but that probably wouldn't send them right to testing first. There are some things you could do later, but it would probably be important to get the imaging study. Okay. So there you go. So don't look at the left side. Can you explain what you see here and give me a differential on what you think?
So here, what you can see, this is an axial MRI image or that is showing, it is an axial MRI image. It is a T1 image with the gadolinium enhancement. The lesion is a lesion, it has a typical ice cream cone kind of appearance. So you have a lesion within the cerebropontine angle, extending or pushing the CP angle or the extending to the cerebellum, and possibly a CP angle lesion that is taking up contrasts. So in terms of differentials, it is either a vestibular schwannoma or it could be an arachnoid cyst.
Okay. What are the most common lesions in the CP angle? Can you give me like the top 3 or 4? You mentioned one, schwannoma, probably the most common.
So you have a schwannoma. You can also have a meningioma.
Okay.
You can have arachnoid cysts.
Does arachnoid cyst, is it going to be enhancing on T1 like this?
No, not really.
Okay.
You can have a cholesterol granuloma.
Okay. Is that a common location for a cholesterol granuloma within the CP angle?
Not really.
Okay. Yeah. So where are they more commonly located?
In the petrous apex.
Okay. What else could you possibly have inside the CP angle? You've got the top 2. You said schwannoma, and you said meningioma. Can you name a couple other things you might find in the CP angle? I mean, they'd be a lot further down the list on possibility, but just for differential sake, what else could you see?
You can have schwannomas of other nerves. So either a facial nerve schwannoma, trigeminal, any nerve that passes through the CP angle.
Okay. Aside from schwannoma or meningioma, what other tissue types what else could be there?
Yeah.
Just name some other things that you might find.
Gliomas
Sure, it could be a malignancy, right? Could be a metastatic
or a
lesion, right?
metastatic lesion, yeah.
What cancers would commonly spread to the CP angle?
Uh, Thyroid, breasts, renal, prostate, and ovarian, genitourinary. Yeah.
Okay. How about any blood-related malignancy or
Or
cutaneous
lung,
malignancy?
lung or leukemias. You can also have metastatic lesions or even lymphomas.
Lymphoma.
Yeah.
Okay. What about any skin cancers that could spread to the inner ear or that region? Do you know of any other types of cancers that would be
So melanomas,
melanoma,
yeah.
right? Melanomas can spread there. I've seen that. Melanoma, lymphoma. I would say breast is probably the most common, prostate, renal. Yeah. Can you think of any other benign tissues that might be in there?
You can also have epidermoid cysts,
Sure. Yeah, absolutely. Anything else?
lipomas.
Lipoma. There you go. Exactly. Good. Yeah, right. So you can have a lot of things. What is a choristoma? You ever heard of this term, choristoma?
Yeah, a choristoma is it's usually a lesion that comes from it is commonly found in the ear. It is commonly found in the external auditory canal, and it comes from the apocrine glands
Mm,
or
a choristoma
yeah.
is actually a term used for, it just means an ectopic location of normal tissue.
Okay.
So you want to look that term up.
Mm.
Um, I saw it once on a CP angle. So